first session is on COVID regional responses. We have two of these, so we're delighted to hear from people all around the world, in the Antipodes and beyond. And to chair this particular session, I'm delighted to welcome Helen Lambert, who's Professor of Medical Anthropology at the University of Bristol. Can you make yourself aware of us, Helen? Pop your face up and let's see you.
I'm here.
Hello there, how are you?
I'm good, thank you.
Are you brave enough to admit something you got slightly wrong that didn't turn out as you thought it might do during this pandemic?
Right at the beginning, I have a portfolio of research in China, so I've been sort of living and breathing this right since early January. And I guess a key mistake was my believing that the Epidemic Preparedness Index, which was well cited, I think it came out in the BMJ in 2018, which said that the UK was one of the best prepared countries in the world, and Southeast Asia was poorly prepared, might actually be right, and that we might do very well and be well able to control COVID-19 in the UK.
And as that hasn't proved to be the case, but do you think, what was the one single factor that hasn't made that the case, do you think? Why? Because we treated it like it might be influenza, or what do you think?
It's unlike influenza. I think a lot of mistakes were made early on by assuming it was the same. But I also think we're probably going to hear about issues in this first session, which may have to do with border control, which has been notably problematic in the UK.
Okay, so that's a good way to introduce your panel. Tell us who your panel is, and then I'll hand over to you, Helen.
Okay, well, I'm really delighted to have an extremely distinguished panel here this morning. So we're going to be dealing in this with the first of two sessions looking at country and regional responses. And we've got Professor Michael Baker from the Department of Health at the University of Otago speaking about New Zealand. We've got Professor Ramanan Laxminarayan, who's director of CDEP, a very well-known center who's based in New Delhi in India. And we've got Gabrielle Young, who's the Dean of Medicine at the University of Hong Kong, speaking on East Asia. So I'm really delighted to welcome this very distinguished panel. And in my second hat as the challenge leader for UK Research and Innovation, leading the Global Challenges Research Fund for Global Health, their global health portfolio, it's fantastic for me to have the opportunity to hear more from this panel about the key known unknowns, including just why these different countries have had such diverse experience of the pandemic. So without more ado, I'd like to hand over to our first speaker. Each speaker will have 15 minutes and I will be timing you. I will pop up back on the screen about a minute before you're due to finish. If you finish before 15 minutes, we'll just go straight on to the next speaker because we're hoping to keep all the questions and discussion for the 10 to 15 minutes that we'll have at the end of the day. And just to repeat what Phil said, we're tweeting, those who are Twitter users, we're tweeting on COVID unknowns. Unknowns, COVID unknowns. So over to Professor Baker. Thank you.
Well, kia ora from New Zealand, and thanks, Helen, for the introduction, and also Fiona and Phil for the opening words, and also particularly to George for the invitation to join this really fascinating day. So I'll just get my presentation up, and so as you can see from the program, I'm going to talk about the New Zealand experience with COVID-19 elimination. And I'm going to talk about the strategic choices countries make, the components of the elimination strategy, its impact, a few key questions, and hopefully some of the generalizations from our experience. So infectious disease epidemiology suggests you've got this dichotomy between control and elimination. We can pretty much try and control all significant infectious diseases, usually sometimes mitigating pandemics to avoid overwhelming systems, or quite commonly suppressing to low levels to minimize adverse effects. With elimination, of course, the goal is to reduce the incidence to zero in a defined area. And occasionally, and this is obviously a very high bar, global eradication, where you reduce the level to zero at a global level. And obviously that's really achieved. So like many of us, there were certain moments when we thought we really needed to be very concerned about COVID-19. And I remember really late in January or during January, realizing this was going to be a serious global pandemic based on, I think, very good reporting from Hong Kong in particular. And then I think that was a bit depressing. And then late in February, there was, I think, a much more optimistic evidence coming out from the joint WHO-China mission, showing that almost the impossible had happened, that actually China had contained and eliminated this pandemic really in full flight. So that convinced me that elimination actually was an attainable goal. And of course, in March, when we were having quite well-established local transmission in New Zealand, realizing that we were not ready, we didn't have the testing and contact tracing capability to contain this pandemic, so that we needed an intense lockdown. So some of the evidence feeding into our decision-making, of course, like most countries, we did modeling work to work out what a poorly controlled pandemic might look like in New Zealand. And our estimates were that it would be a mortality of about 0.3% of the population, or equivalent to 25 seasonal influenza seasons stacked on top of each other. It's not quite at the same scale as the 1918 influenza pandemic, but still a very significant disease burden. Another major factor in New Zealand was concern for equity. And this is showing 100 years of experience with influenza pandemics. And you can see here, looking at the European population set as a baseline, there's a markedly higher rate ratio of mortality for the indigenous Maori people in New Zealand. And this was a huge concern for us. So we were following very much the mitigation strategy, like I think almost every country on earth. We had a pandemic influenza plan. It was about flattening the peak. And this was the model we were using in New Zealand until mid-March. And I think this is still more or less the model being used across most of Europe and North America, sometimes with a lighter touch with herd immunity, more often now evolved into a suppression strategy, which is really trying to minimize adverse health effects. So during this period, we were thinking hard about an elimination strategy, and we published a version in a few places now. And this was adopted by the New Zealand government effectively on the 23rd of March, with a decision to pursue a very intense lockdown when we had only about 100 cases and no deaths. So we defined elimination as we progressed into this as a sustained period with no identified cases, with a high performing surveillance system, and obviously excluding cases that were safely quarantined at the border. So obviously we all think very hard about getting the reproduction number down. We can't really change the duration of infectivity. So we're obviously dealing with these non-pharmaceutical interventions that will push down transmissibility and contact rates. So this is the mix of, the quite limited mix of options that you have available. So the elimination strategy is really about excluding cases, so keep it out at borders, case and outbreak management, stamping it out, testing, contact tracing, and so on, and dampening down transmission in the community with really the only two things we can do to achieve that. So this was one of many remarkable graphs that we never expected to see. This is the number of people arriving in New Zealand, reduced by over 99%, with travel restrictions and also a requirement of 2 weeks quarantine and eventually 2 negative COVID-19 tests. So there were 1 or 2 days in here when no one came into New Zealand or left, and people had to look back through decades to see when that had last occurred before this period. So the second key strategy, of course, is high volume testing and contact tracing. And like many countries, we went from no capability to very high test volumes in New Zealand. The third strategy, again, is dampening down transmission. We obviously promoted hygiene measures, the traditional ones of staying at home if you're sick and wash your hands and so on, respiratory hygiene. But of course, when you know more about COVID-19 transmission, the role of asymptomatic sources and respiratory droplets and aerosols, you realize you really do need masks to interrupt transmission and mass masking. And this was not really a feature of the New Zealand response. I'm just showing you, this is a result of promoting masks. My face or version of it is now on a mask sold at the National Museum in New Zealand for some reason. So the other component, of course, of dampening down transmission was physical distancing. We adapted this alert level system. I think it started in Singapore, and this became a very effective form of risk communication to the public. And I won't go into all the details here, but they'd be familiar to you. Level 3 and 4 was effectively the stay-at-home order or a circuit breaker level. So New Zealand finished up with the most stringent lockdown in the world based on the Oxford Stringency Index. So we had 5 weeks of very intense lockdown, then 2 weeks at level 3 for us. So after 7 weeks, we emerged into a COVID-19 virus-free country. So this was rush hour in the main motorway leading into the capital of New Zealand, Wellington, and probably not a scene we're going to see again unless we fully decarbonize our society at some point. So this is the effect of the lockdown, and we went from an effective reproduction number of about 2 prior to the lockdown. So we were transitioning from imported cases to local transmission, and we were on the beginning, of course, of that exponential curve. So level 4 lockdown was very effective at suppressing transmission with an effective reproduction number of 0.35. So this is a very condensed summary of the epidemic curve and the phasing in of control measures that we published in the New England Journal of Medicine. And that really summarizes when things were phased in New Zealand. And so we had this period of 100 days with no transmission. And this is showing where, because of the number of cases in New Zealand, they're all sequenced. And this really was very revealing. And it's been great to have this tool. And this showed that we pretty much imported viral lineages from every corner of the globe. We had a large number of introductions, but only 20% of them resulted in sustained transmission. And I think this is one of the principles of this virus that is very relevant to its transmission and control. So the impact of the measures in New Zealand, the overall COVID-19 mortality was 5 per million, so the lowest in the OECD, about 100-fold less than many countries in Europe and North America. So what are the, I guess, the key questions and conclusions we can take from this experience? Can we sustain it? Do we have to sacrifice your economy to eliminate? Is it generalizable to other jurisdictions and to other pandemics? So this is really showing the epidemic curve subsequently, and you can see we've had some border incursions. All of these have been controlled, so we've had 8 discrete events. So it looks like the approach is sustainable. And that's with continuing the more focused approaches of high-level testing, contact tracing, far less use of the alert levels, no further use of lockdowns, and we've now phased in mass masking in key locations. So what about the effect on the economy? So this is a very busy slide, but this is really showing our framing of the choices countries make. You have exclusion, which is what a lot of Pacific Islands are doing. They've lifted the drawbridge. They have no cases at all. Elimination, really, I think the predominant approach in Asia or East Asia, certainly mainland China, Taiwan, and Vietnam, and a number of other countries. And the goal is to emerge into a virus-free country after a period. And whereas much of the rest of the world is moving between mitigation and suppression, which our assessment is that means really prolonged and recurrent lockdowns and other measures to suppress transmission. So this is impossible to read, this slide, but this was our summary really of the experience in terms of mortality in larger states in Europe and North America and in East Asia and Australasia, showing the markedly lower COVID-19 mortality in countries pursuing elimination, but also the second quarter GDP showed less contraction in countries that were pursuing elimination. And the third quarter GDP results are just coming out now and showing the same pattern, but we haven't got all of them yet. So is this generalizable to other country settings? And this is, and I believe it is, this is showing the experience of Victoria and Australia, which is this curve here. They had a major resurgence there, and the intensity was higher at that time than was being seen in the UK based on cases per million. And so just the what they did there was they introduced a lockdown which became very intense, somewhat similar to New Zealand, and this basically was followed by elimination of the virus there. And so it does suggest that even with a very well-established pandemic wave, you can actually eliminate this virus. So one other observation is this approach generalizable to other pandemics? This is showing the experience in New Zealand with influenza this year. Our normal seasonal curve is very marked, as you expect for a temperate country. This year, we have had no influenza, essentially. We've had 6 isolates over this 5-month period. None of them resulted in sustained transmission. So one of the messages for us is that this set of tools now can be used for almost any respiratory pandemic disease. And so we've got this new set of tools, and I think that could really rewrite the current approach to managing pandemics. One other consequence was that excess winter mortality has disappeared in New Zealand this year. And that is an indication that this is actually driven by respiratory infections rather than the physical effects of winter. And so all-cause mortality in New Zealand has dropped by 5%. So that translates into 1,500 people who will live out this year into next year who wouldn't normally have survived winter. So the conclusions I would really like to make from this experience is that elimination is preferable to mitigation based on public health and economic benefits. It can be sustained, I think, in a wide range of jurisdictions with very varying geographic, political and socio-economic contexts. And it may well be the preferred strategy for responding to new emerging infectious diseases with pandemic potential where they have moderate severity, particularly while key parameters are being estimated. And my other major lesson is really the critical importance of effective science and good political leadership, because as we all know, it's extremely frustrating if you have one without the other. And I just want to acknowledge my wonderful colleagues and a number of collaborating organizations. Thank you.
Many thanks, Michael, for that perfectly timed start to the day. You finished with 20 seconds to go. So you are not only setting the highest possible bar for speaking, but also, of course, an extremely high bar for a success story in the shape of New Zealand, which I think has become something of a model in all of those respects around the world. We're going to move straight on to Professor Laxminarayan, who I believe has now joined the panel. Ramanan, great to see you. Good, thank you. Perfect timing. So great. If you're ready to go, I'm going to hand straight over to Professor Laxminarayan, who is the director of the Centre for Disease Dynamics, Economics and Policy in New Delhi, India, has been a world-leading authority for some years already in the field of antimicrobial resistance, but has now also been working extensively on COVID-19, and particularly in the super country of India. So over to you, Ramanan. I'll come back on the screen about a minute before your time is up. And just to let everybody in the audience know that we're tweeting from this event on #COVIDunknowns.
Thank you, Helen. Oh, thanks, Helen. Thanks to you, George, and the other organizers for inviting me. I can assure you that India will not be able to match New Zealand with respect to control of COVID. That's almost certain, but I'll at least try to stick to time so that I can at least get one of the objectives in. So I'm going to speak on one particular study, but just because that's where we have much of our data on what happened in India. India is obviously not one country; it's an entire planet onto itself, and huge variation. So what we know in some places, certainly don't even apply across the country, let alone to the entire world. So India's had a tough challenge with COVID, and I was certainly one of the, in the early days of COVID, I had hoped that this would just sort of die out in China, as many people did. But I think by February, it was quite clear that it wasn't going anywhere. And fortunately, India was very proactive in how it dealt with COVID. The number of cases and deaths in India have been, increasing over time. Now, these are not complete because only till August I had to update these, but we've had a bit of a dip in cases, but now it's starting to go back up again. And one reason why we didn't really have a good view of the epidemic is because testing levels were really quite low in India at the beginning. Samples tested per million, even today in India, rank above, say, 90 in the world rankings, even despite India having a huge number of cases. It's catching up, but many of the new tests that are being done, are rapid antigen tests, were not quite as clear in terms of counting cases as RT-PCR, as we all know. Now, there have been 4 phases of lockdown. The first lockdown was imposed very early on 25th of March. And I think the one thing we can give India credit for is for having recognized the importance of the epidemic. And India stopped travelers coming in from China way back in late January itself, actually after the 20th of January, and then arranged for repatriation flights to bring people home. There were a couple of cases of COVID back then, but the actual first cases, following those first couple of cases, was only in early March, to the best of our knowledge. But of course, who knows? They might have been there before, and we just didn't even know about it. But the lockdown happened, and a very strict lockdown was imposed nationwide. And the main reason for this lockdown was simply because it was dealing with a pandemic that no one knew where it was. So the lack of testing really made it impossible to have a much more calibrated lockdown, which would have been far more preferable, because it is almost certainly the case that some states in India had absolutely no COVID at all back then, but were forced to lock down just because you couldn't lock down some parts of the country, but not others, without sufficient evidence. So if there's one lesson to learn from India is, the testing early would have helped, and the testing capability was available, but wasn't deployed for reasons that are not entirely clear. Now, in the second phase, there was some easing of the lockdowns, particularly in some districts which were considered to be less of a risk. And it took all the way to June when some semblance of the strict lockdown, came to an end. But even today, trains don't run as frequently as they normally do. There really isn't a resumption of air travel at the levels that there were before. And so in some sense, the country is not really back to normal. And these were the 5 unlock phases. We're in the 5th one, actually, or towards the end of the 5th one. So travel is permitted, but it's not frequent. Now, in the 2 states in which we work, so there are actually 2 states here. One is Tamil Nadu, which is down south. The other part of this would be Kerala, and here's the Bay of Bengal. And here's Andhra Pradesh, which was split off from the other part of Andhra Pradesh that is now called Telangana. And we've been tracking the epidemic in these 2 states very closely, working closely with the government, starting from early May through June and July. Now, the combined population of these states is about 120, 125 million people, and obviously, slightly bigger than New Zealand. And So, they had early epidemics which started in the urban areas. As in most countries in the world, they started around the international airports. In Tamil Nadu, it was Chennai, and there really isn't a major airport in Andhra Pradesh, but certainly, Visakhapatnam and Vijayawada are two of the big cities where things started out. And you can see that over just the course of the epidemic, the number of cases had gone up quite significantly. This paper is out, by the way, so I should have changed that from Science Forthcoming to it's already published. Now, all of these districts we had very detailed data on, and as you can see, the lockdown did have had some sort of an impact on each of these. These are over age groups, and you can see that there seem to be fewer cases in the lower age groups, and with the predominant number of cases really in the middle age groups, the 20 to 60 is where we see much of the cases. Now, overall, in our data set, we had about 435,000 index cases, data on about 5,700 deaths, and about 575,000 odd contacts that were traced from these 84,965, sorry, I should have corrected myself. We had 84,965 primary cases, and we had all these other contacts. Now, the contact tracing actually reached a much larger population. We had data on all of these, but we didn't have reliable testing data on all of them. But it reached 3 million people, known exposed contacts. But like I said, we had the testing data from a subset of this much larger number. And most of the data actually come from Andhra Pradesh, much more than they do from Tamil Nadu, just because Tamil Nadu, the data were really rich, but they weren't being reported out in a timely manner. But in the early stages of the epidemic, we had more Tamil Nadu data. Now, trace contacts tended to be younger, were more often female than their linked index cases. And the folks that were identified through the contact tracing were a little younger and less likely to be male than the overall population in the two states. Now, you can see the attribute of the cases and the tested contacts not hugely different, quite similar, and the differences are really quite small. Now, again, if you look at the contacts tested and the test positive contacts, again, not a significant difference between the two. So, doesn't seem to be that different at all. Now, if you're looking at contact definitions, a person was deemed a high-risk contact if they were in the categories on the left, and a low-risk contact if they were in the categories on the right. So if they touch bodily fluids, if they touch their linens, or lived in the same household as the index case, or very importantly, if they traveled within the same row or within 3 rows of the index case for more than 6 hours, they were deemed a high-risk contact. And if they were traveling but not within that definition, they were considered a low-risk contact. Now, the epidemic really took off much faster in Tamil Nadu than it did in Andhra Pradesh. You can see that the blue, that went up quite fast. Andhra Pradesh was a little later catching up, and then caught up quite significantly after that. And the two states are still pretty much neck to neck. They still have some of the highest caseloads in the country. And these are two states with relatively good health systems compared to the rest of the country. They have a legacy of having dealt with HIV/AIDS, and therefore an ability to really do the kind of contact tracing that was possible here. So these are numbers for cumulative incidence and mortality. As you can see, a steady climb over the period of time. This is the distribution of index case ages. So you can see that so this is for all by index case ages by contact age, and this is for high risk index cases. So you can see that the folks who were transmitting were really the folks in the 20 to 40-year age group. They were the predominant sort of transmitters of the infection, regardless of who the contacts were. So possibly because these were folks who were going around, they were traveling a little bit and so forth, even though for much of the period, there was a lockdown in place. Now, we look at the same figure by infected contact rates. So the previous numbers were on just contacts. And when we look at infected contacts, you see there's a very sharp 45-degree line, regardless of whether you're looking at high risk or all index cases and contacts. If you look at high risk cases, for instance, you see that people were mostly transmitting to people of their own age. There is some amount of transmission from people in the 20 to 40-year age group to the children, which I'll pick up on in just a bit. But these are the two big red splotches that you really see that are worth noting. We found secondary attack rates were quite similar to those reported from other countries. About 1 in 10 for household settings, which is what Chinese study and a South Korean study from the early days of the epidemic showed. Much higher secondary attack rates, 79.3% for people traveling together. So this is a high risk travel, and that seemed to be worth noting. Not a huge amount in healthcare settings, certainly if you take it overall, even in the community setting, not a huge amount. But overall, any setting is about 7.5%. This is the distribution of the frequency distribution of contacts tested. But I would draw your attention to the right side, where what we note is that 71% of the index cases didn't transmit to any of their contacts. And in fact, of the remainder, something like 8%, so this is the 92 percentile to the 100th, 8% of the infected index cases were responsible for 60% of all of the secondary infections, indicating a significant effect of what people before us have called super spreading, a term which I'm not super comfortable with, just because people imagine super spreading to be these sorts of people going into a marketplace or a wedding and then transmitting to tens or hundreds of people. That's not really what it is. It just is that there's heterogeneity in transmission. Some people transmit, and most people, at least in our study, just do not. And if you look at high risk contacts versus low risk contacts in terms of a probability of a positive contact, obviously higher. Not a huge variation by by gender or depending on whether the index case or the contact were male or female. Now this is interesting because here we see case and contact ages, and we see again the same picture, which is that regardless of whether it's a high risk or a low risk contact, that people were transmitting mostly to the same age group. So essentially, kids transmitting to kids, adolescents to adolescents, the young adults to the young adults, and so on and so forth. And here you see very, markedly the elderly also transmitting to other elderly people. Now, this was surprising because in India, you think that there are multi-generational households, so maybe, everyone transmits to everyone else. Certainly that happens because all of these are, above zero. But the preponderance of transmission seems to be within the same age group, which was a surprise. And you see that again in these pictures, which is the 45-degree slope is really the darkest, which means that if you look at the index case age and the contact age, especially if you look at high-risk contacts, given exposure, that this is where you see the most, and you see that little blotch on the top right, indicating the elderly really are transmitting much more to the elderly. Now, we also had data on time to death, and we saw that, of course, men were more likely to die than women. We also saw a greater survival advantage as the months went by, perhaps indicating that, that with improvement of medical care and knowing how to deal with the epidemic, potentially the mortality was coming down. Slightly higher in Tamil Nadu than Andhra Pradesh, although that could be an artifact of where we had a lot of the data. And remember that Tamil Nadu had more of the deaths from the earlier age groups, from the earlier period of the epidemic. So this is perhaps not directly comparable. But what you see here is that, the adjusted hazard ratio shows that, there's obviously the differential in age in terms of time to death. And if you look at case fatality ratios, and you look at the very bottom, the highest, 85 plus years, 16.6 in all cases, obviously higher in the males compared to the females. This is quite similar to what we've seen from other countries. What we've seen that is different from other countries is that if you look at the case fatality ratios in the 40 to 75 age group, they are quite a bit higher in our population compared to other populations. In fact, if you look at it directly from reported data from Italy, China, Brazil, US, and India, India has a lower case fatality ratio in that oldest age group, probably a survivorship bias. People who've reached that age are probably alive for reasons that they didn't die of chronic disease earlier. But once you get to the lower age groups, particularly 60 to 69 and 50 to 59 and 40 to 49, you see that folks from India in that age category have a higher case fatality rate. And that is of concern and probably reflects high rates of comorbidity, exposure to air quality, bad air quality, and so forth. Now, this is
Ramanan,
yeah.
just to let you know, you've got less than 1 minute left.
Less than 1 minute. Okay, I'm going to rush the next couple, and then I'll wrap up. So, which is so if you look at all cases, we see that men do die faster, and also the population in India, folks die. Half of the folks die within about 5.5 days of being tested, and the equivalent rate is about 2 weeks in China and about 13 days in the United States. And you can see that overall, comparing to the United States, we see a much larger death distribution in the middle age groups, which is really the point of concern. Now, I'm not going to talk about the reproductive number, but just the point to note that the lockdown, which started with an R of T over 2 to 5, ended up with knocking the infection down quite significantly. So that's clear evidence that the lockdown did work to some extent, but was obviously didn't have the kind of effect that it had in some other countries in totally eliminating the infection. So just to wrap up, so the risk of transmission, quite similar to other countries, children and young adults have an important role in transmission. Super spreading or heterogeneous transmission is the rule rather than the exception. And this is just to reiterate what we said. And this is, to the best of our knowledge, the largest empirical demonstration of this kind of heterogeneous transmission. Unlike in high-income countries, deaths are concentrated in 40 to 64 years. And you can't really account for these fully by differences in population age distribution. And lastly, the median time to death is about 5.5 days following admission compared to much longer hospital stays in high income settings. And we see significant reductions in the reproductive number as well. So the unknowns, which are all things that we're working on, are.
And you're out of time now, so can you?
Okay, that's just the last slide, and I'll leave it there. Thank you very much. Thanks, Helen.
Thank you very much indeed. Sorry to rush you. I can see why you have so much fascinating data. That was an amazing presentation. And there'll be a lot of really interesting things to think about in terms of comparison, for example, with Africa, where different demographics have also been mooted as a possible reason for relatively less fatal responses in some countries. But I'm going to move on straight away now to our final speaker in this session, who is Professor Leung, who is based at the University of Hong Kong and the Dean of Medicine there. So thank you very much for joining us, and over to you, Gabriel.
Right, thank you very much. I hope you can see my screen. Thank you, George, and thank you to the BMJ also for allowing me the opportunity to share a few thoughts about what do we know from East Asia that is still unknown, the so-called known unknowns. And I hope that I belong to James Mackenzie's first group of ignorant people, as George has put it in his IJE editorial 4 years back, if I remember correctly. So here is a map of the COVID-19 case burden around the world. And if you look at East Asia, that includes Southeast Asia as well as Northeast Asia, you see very, very different numbers compared to Europe and in North America. And of course, here in this panel, you see that you have the original epicenters actually were all in East Asia, and yet this is the picture so far, 11 months in. And of course, the heat map here gives you the quick overview of the world. The darker you are, the more trouble you appear to be in. This, I submit to you, is probably one of several reasons why this might have become the case. So if you actually focus on these major epidemics or pandemics in the last century, 2 out of the 4 flu pandemics actually came from East Asia. The eponymous Asian flu and the Hong Kong flu in 57 and 68, respectively. You also have the first major avian human influenza outbreak, H5N1 in 97, that was in Hong Kong. And then the next big one was H7N9, centered around the Yangtze River Delta in mainland China, that subsequently spread to southern China. And of course, the coronavirus outbreaks of SARS-1 in 2002, 2003, centered around southern China, as well as the present one in the middle of actually the country. And of course, South Korea had a very sizable hospital cluster of MERS as well. So I think that if you, and of course, I forget the very, very big hand, foot, and mouth disease outbreaks, particularly in the pediatric populations, since 2008 in much of East Asia, including, of course, China, Singapore, Vietnam, and these have lasted really for well over a decade. So if you actually look at all these big pandemics or outbreaks, regional outbreaks, most of the directly transmissible respiratory pathogens really came from East Asia, or were first detected in East Asia anyway. And I think that the sociological imprinting, and therefore the subsequent lessons learned, and preparing the psychology of the population to respond to the next big one, again, very, very similar to perhaps previous respiratory pathogen outbreaks, might have something to do with it. Now, of course, governance systems is a second very commonly cited reason why things might be looking quite different in East Asia, including, of course, Australasia, than much of the other parts of the world, with the exception of Africa. But I think that's for a completely different set of reasons. Now, this is a third reason that is often cited, and that is the willingness to respond with personal hygiene or personal protective measures, as well as adherence to fairly draconian and harsh lockdown measures. So if you actually look at this, this really is face mask use at the top here. You can see that all these places are in East Asia versus the US and Europe. So again, a very striking contrast. Now, this is a very recent cartoon that I saw on Twitter. Ironically, his favorite saying was, beware of what you wish for. And of course, on his tombstone, it reads, give me liberty from masks or give me death. So this is something that George mentioned in his opening slide. And indeed, the WHO, for 6 months, actually prevaricated on the use of masks for COVID, and only, I think, on June 11th, actually issued the latest strong support of mask wearing. And why did the WHO sort of changed its mind? So if you look at the evidence pre-COVID, we didn't really have very much evidence on coronaviruses, but we had a lot of evidence on flu. And in fact, thanks to the US CDC, which funded most of these trials all around the world, so obviously in mainland US, but also in Thailand and in Hong Kong, as well as, of course, Michael from New Zealand was also part of this exercise. And so what our group did just before COVID outbreak was to look at a systematic review of all the evidence of the effectiveness of masks against flu. So you can see that there is some limited evidence, somewhere between 10 to 20% risk reduction of hand hygiene and face masks for confirmed flu. And this is really the best that we have of mask use against respiratory pathogens. And then there was a rapid review published in The Lancet on face masks against the coronaviruses, so SARS, MERS, and COVID, but they were mostly in healthcare settings. So if you actually look here, most of those studies reviewed were in healthcare settings, and fairly large risk reduction, 70% risk reduction for in-hospital settings. And then so-called non-healthcare settings, you still got 66%. But it's important to note that in fact, 1 out of the 3 studies were referring to visiting family members with SARS in hospital. So that's also actually a hospital exposure. But maybe this effect size was not really believable. The level of evidence was not very high. And so there were some questions about the quality of those studies. Now, if you then look at some mechanistic studies, this is a G2 machine, which was put together and invented by Don Milton, who was at Harvard and then now is in Maryland. And this machine basically collects the exhaled breath of patients and then looks at these exhaled particles and split them into coarse fractions that's greater than 5 micrometers or fine fraction less than that threshold. And what we had done before COVID, although the work was published just at the beginning of the COVID outbreak, we looked at that and we saw for the 4 seasonal human coronaviruses, in fact, mask wearing, whether it's for droplet spread or for aerosol spread, actually was eliminated by surgical face masks. And we didn't see that for flu, and we didn't see that for the other respiratory viruses. Now, a third strand of evidence that we looked at was, so here you can see quite faintly in gray, the epicurves of the Hong Kong outbreak, the first, the second, and the third wave. And you can see that the top line in red is actually face mask wearing. So essentially, Hong Kong basically had universal masking from as early as the end of January or the beginning of February, all the way through. It's almost universal masking, 100%. Yet, despite that, we still had these fairly sizable outbreaks. So it shows you that it's probably insufficient to just rely on masks to stop community outbreaks. Now, the Danish trial that George referred to, this is actually the key table in there. It actually shows 18% risk reduction for this primary outcome. And in fact, the point estimate is spot on with the influenza mask studies. But of course, this crosses unity. So a few things to note. It's underpowered because in the power calculation, they assumed a 50% risk reduction. So from 2% baseline prevalence down to 1% baseline prevalence. But a priori, if you actually look at the empirical evidence against influenza, you wouldn't have assumed that this should have been the prior. Secondly, there was actually no IRB. Third, the follow-up was only 1 month. And fourth, fairly loose serostatus ascertainment, so essentially diluting the magnitude of efficacy, or actually pulling that confidence bounds quite wide. So a negative result in this trial does not mean that masks don't work because of all these things. So that's a big sort of known unknown. Do they work? And if so, under what setting? Because we still haven't seen definitive RCTs, but a lot of suggestive evidence around that. And a few other sort of known unknown questions is the Swedish model of pandemic control versus the rest of Scandinavia, Sweden versus the rest of the EU, and then of course, what is that approach versus the suppress and lift? And of course, there was a recent study studying quite a few countries in East Asia, as well as other countries that's published in The Lancet that a few of us put together from around the world. Still unsettled questions. Science or politics, the Great Barrington Declaration versus the John Snow Memorandum. Two very, very different groups, two very, very different philosophies. Is it science or is it politics? Then here is a graphic from the FT, which has been replicated many, many times in the recent weeks, showing that on average, places that were hit hardest in the spring are still suffering the most in the autumn, winter. So is that ecological fallacy or is it subthreshold short-run effect? So we will find out all in the goodness of time, but these are known unknowns that we must address post hoc. And then testing frequency versus sensitivity if everything else is held at the same. And this is a paper, a preprint from Michael Mina at Harvard and his colleagues showing the use of different testing platforms and then compensating for perhaps less than perfect sensitivity compared to the gold standard PCR. Another known unknown is what is the utility and drawbacks of contact tracing apps? These are the so-called contact tracing health codes used in mainland China to very good effect, but is it widely applicable elsewhere? And then another question that I have always sort of had at the back of my mind is what is the search capacity of contact tracing in terms of the comparative reflections with flu? We never used to do this kind of thing with flu, except for when we have the sort of once every few decades flu pandemics. And we could only do that for the first few hundred cases. What would be the implications for the future? How do you get prepared? And of course, when you have things that are so clumpy, that is so over dispersed in statistical jargon, where you have anywhere between 10 to 20%, as Ramanan was also showing you some Indian data, really very much in concordance with the Hong Kong data shown here, that 10 to 20% of all infections were responsible for 80+% of transmission events, where 70% of cases didn't really go on to infect anybody else. So very clumpy nature. How does that affect contact tracing? Still an open question. Just like to thank the funders of our work and of course the key people who have been responsible for much of this work. Thank you very much indeed.
Thank you very much indeed for that fantastic presentation. And I was just about to cut you off and didn't need to because you finished with perfect timing. So thank you very much to all of our panel who've raised a host of absolutely fascinating questions and issues, starting to point to some of the possible knowns unknowns from history as influential that we've just heard about in terms of prior exposure to previous pandemics that may have helped to prepare societies for this kind of impact through governance and policy, in particular New Zealand's innovation to moving away from the kind of influenza containment suppression model to an elimination model, the willingness to adopt non-pharmaceutical interventions such as masking and cultural preparedness to do that, through to issues around the heterogeneity of transmission that we heard in particular from the amazing data that was shared by Ramanan. We've got a fantastic team working behind the scenes, going through the Q&A, and we've had a lot of questions popping up on the Q&A. And I wonder if I could ask Nikki to come on screen to share with us some of the key questions that have popped up to ask the panel to respond to.
Yeah, of course. And thank you so much to all the attendees who have been sending through questions. So we'll start off with a question for Michael about New Zealand's strategy. So a lot of, I think, our UK-based listeners are wondering whether New Zealand's strategy might have been possible for us to do. And sort of following on from there, would we be able to reset and do a New Zealand approach from where we are now in the UK?
Yes, look, I don't think there's any biological reason why the UK couldn't. And I know throughout the last few months, I've had many conversations with colleagues in the UK, I think possibly more in Scotland and Ireland, where they have been at points where they felt that elimination was very feasible. So I'm not sure if there are any barriers. I'd be interested to know if any of the other panelists think there are any biological reasons why this couldn't be achieved. And as I illustrated, I think the experience in Victoria, Australia, illustrates that even a very intense, entrenched epidemic wave or pandemic wave can actually be interrupted with an intense lockdown, but with the view to coming out the other end with no remaining cases in the community, as opposed to going in and out of lockdown, which I think is a very different endpoint.
Thank you so much. Do any of the other panelists have anything they want to add to that, or should I move on to the next question? I'll move on. So I think this question came through during Ramanan's talk. So regarding most transmission being to people of a similar age, does this suggest that age groups have different strains of a virus, or that different strains of the virus suit a particular age group?
I think the most likely explanation is just that there's far more social interaction between people of the same age group, even in mixed households. And we didn't realize that it would influence the transmission to the extent that it did, but it certainly seems to. It's also possible that the duration of contact for people within the same age group is actually greater. I don't have any reason to think that there's something to do with the virus that would make it age-specific transmission, but yeah, that seems unlikely, but maybe Michael or Gabriel have a thought on that.
Thank you so much. Another question that I think is for all of our panelists that there's been some discussion on in the Q&A is, what are your insights and predictions as to how this might end? Gabriel, do you want to start off with that one?
I think a feng shui master might be a better person to answer this question. But let me just say this. I don't think that the current first generation of vaccines is going to be the silver bullet that many of us are hoping for this reason. Because the primary endpoint of most of these trials, or certainly for the ones that have reported by press releases already, they concern symptomatic illness. They don't tell you very much, at least not in the press releases, about the much more important or relevant outcome or endpoint as far as transmission goes, whether they actually provide sterilizing immunity. That is, that they would stop infection altogether. And unless they are able to stop infection altogether, transmission would carry on. And as such, the best that one can hope for is that symptomatic illness, the efficacy that is being reported is applicable equally to mild, moderate disease, all the way through to severe disease, including mortality. And if that is the case, I think it would already be a huge help to the pandemic control effort, but that is not going to bring a definitive end to this pandemic. Unless you get sterilizing immunity, or for that matter, the majority of the world's population all get infected and all recover and all then produce either cell-mediated or antibodies to protect themselves. This is going to be a very important tool, but it will remain one out of many tools that we will need before this will all settle down and before we can go back to pre-COVID type of setting. Over.
Do any of the other panelists want to come in with their thoughts on where this is going to go?
Well, certainly in countries like in New Zealand and Australia, and I think others pursuing elimination, we would be continuing with exactly the same mix of approaches as we have now, which seem very sustainable. And we're obviously looking to see how effective vaccines are, and I'm very much picking up on Gabriel's point about the effectiveness at interrupting transmission. So hopefully we'll have those data in the next few months. But of course, like everywhere, we are ordering vaccine in the hope that it will be very effective.
And I think in India, it's not going to, I think the disease is going to rush through get to most folks. So we'll hope for the sterilizing immunity, because that's probably going to be more reliable than getting the vaccine out to 1 billion people, which is going to be quite a challenge.
Mm.
Nikki, do we have time for one more quick question?
Should we go for one more? Okay, this one's quite relevant for the regional responses panel. So someone was wondering how we can ensure on a global level that we are able to share data about vaccinations, such as vaccination passporting and testing, such that, that data can be made available in a trusted and secure way across the globe.
Should I have a go first?
Sure.
Now, I think that it's important to study vaccine rollout, and really we need to set up a very good observational phase 4 study of all of the vaccine platforms, because only when you do that can you pick up very low frequency but perhaps very high impact events. And I think that no single country is going to be procuring and distributing all of the different vaccines that may become available. And therefore, what we need to do is to set up a very good pharmacovigilance mechanism whereby we could actually study these things in real time and then make adaptive decisions, perhaps based on it, because not everybody's going to be vaccinated at the same time because of availability and so on and so forth. And secondly, I think it is important to also recognize that even for the same vaccine, they will be manufactured in regional hubs and distributed, therefore, locally. And so GMP, or good manufacturing practice, will need to be very, very strictly scrutinized, because even for the same vaccine, you may actually get different manufacturing plants that may have slight differences, just like we have very good pharmacovigilance studies going on with generic drugs versus the original drugs. So I think that's extremely important, and I think it's a very, very good point that was raised.
Thank you very much. I'm afraid we're going to have to bring the panel to an end. I think we could discuss this for several hours, or if not the whole day. We've had a lot of questions on the chat. I'm sorry we're not able to answer them all, but please keep them coming in. We've got around 747 people online at the moment. So we've got a great audience, even if, as you know, our panelists are not themselves able to see you all out there. So thank you very much to our fantastic first 3 speakers of the day for a set of wonderful presentations. And I'm going to hand straight over now for the second session to Fiona Godlee.